Good morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have a couple of hearings scheduled for this morning and then an executive session. However, before we get into any of that, please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. The first bill to be heard this morning is House Bill 1042, and I'll recognize the prime sponsor, Representative Rochefort. Did I pronounce that correctly? Okay, good. I can't always claim to pronounce things correctly, but I'm glad I did that.
That's with a name like that, I've heard all kinds of iterations. So you did good. So yes, for the record, my name is David Rochefort. I am representative representing Grafton 1. I live in Littleton, and I'm here today to present to you House Bill 1042. And just a couple of background pieces of information. I am a pharmacist. I'm one of two pharmacists in the legislature. I'm also president of the New Hampshire Board of Pharmacy. The Board of Pharmacy actually, the bill that you have before you has been requested by the board. So I'm coming here on behalf of them to talk about HB 1042. And probably to give you a little background history of 1042, I've been on the Board of Pharmacy since 2017, and I'd say it was probably 2019 or so that this bill was put in place. And just to give the premise of what the Board of Pharmacy does, the Board of Pharmacy regulates the profession of pharmacy on behalf of the citizens of New Hampshire. We regulate the profession of pharmacy to protect the public safety of the people of New Hampshire. So back in 2019, very early in my tenure on the board, the idea of implementing a mandated continuous quality improvement program required by law for pharmacies was put forward. This was put forward by a former board member and a member of the community, and it sounded great. Who wouldn't think that continuous quality improvement would be a good thing? And just to reiterate, that's our goal: is quality in pharmacy. And it's our goal to improve and protect safety in the state. However, as the program has rolled out and been implemented, we at the board have understood that there are many problems the way the bill is written. The reality is this is really a best practices function. As a healthcare professional, we're always looking to improve our quality. We're always looking to improve the way we deliver our quality. But when you stick something in legislature in black and white, in law, that can't evolve the way a best practices can evolve. And that's what we're finding now, that the law says you have to do something a certain way, but the reality is we're all doing this in our practice, but we're doing it in the form that fits best in 2024, not 2019. So the law is antiquated. Furthermore, it codifies something again that we are doing anyway. I think there's a lot of healthcare professionals around this table right now. There's not one of us, I venture to say, that has not been involved in a quality-related event. We're human. There's variables that happen every day that we can't predict, and things happen. But I venture to say that no one has ever found themselves in a quality-related event and then continued on as if nothing happened and bowled through. That's just not what we do. It's not, we as health professionals don't do that. We look to improve. We look to make things better. But if you look at where the law is written, people partaking in this CQI program could wait up to 3 months to do something about a quality-related event. So it just doesn't reflect what's going on in practice. Add this to the fact that the current law is very granular. It steps out. It puts forward a step-by-step manual on how this process is supposed to take place. And again, that is not, I think I've highlighted the point, that's just not practical in today's delivery of pharmacy. The reality is, pharmacy in New Hampshire, and this is not an exhaustive list, but we have community retail pharmacies, which we all see on every corner. We have hospital pharmacies. We have long-term care pharmacies. We have home infusion pharmacies. We have specialty pharmacies, which was my background. We have nuclear pharmacies. We have mail order pharmacies, and we have pharmacies that are in freestanding emergency rooms. That's just in New Hampshire. So to say one size fits all for a continuous quality improvement program is just not, it's just not practical. I'm going to coming to the end of my discussion here, but when looking at how our profession compares to others, because as I mentioned, that we have nurses, we have physicians around this table, we have EMTs in our legislature, and I wanted to see how pharmacy compares to other professions as far as safety and quality improvement. I counted on the OPLC website, which OPLC, these professions are under OPLC, 21 professions, everything from acupuncture to dentists to nurses to naturopathic doctors, podiatrists, even veterinarians. 21 professions do not have something as prescriptive as we have in our law. Medicine has something. It looked like that was more of an interdisciplinary approach to quality, whereas this is. So going out, extending my search a little bit further, I said, well, maybe healthcare is not the only thing that has to do with safety. I mean, nobody would want to be in a building that was structurally unsafe. So I looked at engineers, electricians, and architects. Nothing like this in their laws. Pharmacy. If you added up the rules and laws in pharmacy has more rules and laws than nursing and medicine combined. And although they're well-intentioned, in this case, it gets in the way. We're finding pharmacies that are, having to stop doing what they're doing in order to comply with the law, even though they may have a better system that their company provides them. But in order to maintain the essence of the law, they have to interrupt what they're doing. I did send a letter around. This is from the Board of Pharmacy, kind of highlights what we have here. I think there's a lot of people here that have, will speak, either will speak or sign in to support. I might add, when the Board of Pharmacy originally approached me to do this, they asked me to strike the entire law off the books. And I believe in that. I don't think we need that. I don't think we need the law because, like I said, we're doing it as is. Every practice site is different. They're doing it as it fits their practice. But I did, make a compromise because I did want to, at least recognize the fact that safety is important. I don't think we need a law to do that. So, I put in that first paragraph to keep the first paragraph, but it was the board's original intent to strike everything. So if there's any questions, I'd be happy to answer those at this point.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So let's say that this were to go away. Are pharmacies right now audited by the board as part of maintaining their license? And do you know if continuous quality improvement is part of that audit structure? So that if the law goes away, there's still something in place with the board that contains a quality improvement component?
Yeah, that's a good question. I appreciate that question. And yes, pharmacies in the state of New Hampshire are inspected routinely. Up to, depending on, it's risk-based, but up to, depending on what they're doing, twice a year, depending on the risk base. My pharmacy was always visited once a year. And I think it's important to understand how New Hampshire treats that. I've got colleagues in Vermont, Pennsylvania, New York that have never seen an inspector ever once. And we're in the stores routinely, regularly, and that is part of the. I'm going to also tell you something too, and reluctant to maybe admit this, but I will. So this continuous quality improvement is part of the inspection. So if you look at the law and the whole law, it's pretty bland, it's pretty vanilla. So if there's a mistake, the board can't take that's caught in the CQI program, the board can't taken action on the mistake that's within the CQI program. They're protected from that. You don't want to punish somebody for being truthful. That's consistent around the industry. So really, what the inspectors are looking at is, are you doing it? And that really is all they have really to look at is, and have you taken minutes, or is there an agenda to do that? So it's really, do you have a piece of paper that says you've done it? And anybody reality is could check off, a paper that shows compliance, and that really is, they could comply with that. Yeah, so that's a two-part question. Yes, we're being inspected regularly, routinely, more than any other states, and they are being checked on that.
Follow-up?
So, and just to confirm that CQI auditing happened even before the law. So that's being done by the regulatory body, not by the state. Like ISO, we have independent auditors, independent from the law. So this is something, even without the law, this would be happening.
So even without the law, there are certain standards that have to be followed. Or do you have are you record keeping? Are you training? Are you cleaning? Are you making sure the drugs are not outdated that you have on the shelves? Are the people who you hire adequately trained and certified? And do they meet that? Yes, that's been going on since the advent of, but this is, tracking and tracing and things that a little bit. But I want to add, most companies, if not all companies, have a CQI program outside of the law that is specific to their company and to their training. Not only do companies have it, but many payers require this as well. But the difference is it's unique to their practice setting. So, a CVS, to use there on the corner, is not going to be required to do sterile compounding CQI program because it's not germane to their practice. So it's the things that are out there in 2024 are much better than the law.
Representative Weber.
Thank you, Mr. Chair, and thank you for taking my question. And I'm hoping for a very short
I know.
answer to this question because we're almost behind time already and there are other people waiting to talk. But what I want to know, it's sort of the flip side of Representative McLean's question. You talked about the number of rules that are promulgated with respect to pharmacies. Do you know of any rules that are connected directly to this statute, which might then be rescinded because of the statute? If you know, and if that's not your field, that's fine.
So, no, it is. We do have, so there are rules that are directly related to this that will be rescinded to this, but there are other quality related rules that are not related to this that will remain.
That's exactly what I wanted to know. Thank you.
Representative Merchant, and then Representative Shapiro.
Thank you, Mr. Chairman. Also, thank you, Representative Rochford, for being here to testify. I would like to have you look at the letter from the Board of Pharmacy in bold italics on the third paragraph. Furthermore, the New Hampshire Board of Pharmacy has not documented one case where the RSA has improved quality or prevented errors. Is that?
I appreciate you pointing that out. That was on my notes to talk about, and I didn't. But absolutely, that's the nexus of this is the Board of Pharmacy can't prove or show that this program has improved quality or prevented errors or made things more safe than they were prior to.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. Can you, for those of us who are not involved in pharmacy, can you give an example of a situation that might arise where this statute being overly prescriptive caused a problem?
Yeah, I can. So a patient comes in for a blood pressure medicine and it gets filled with a blood thinner. Big problem. I mean, huge, the physicians here understand that could be a big problem. So the wrong drug in the wrong bottle. The way the law is written, I mean, that's something that should be rectified immediately. And that's something that the root cause should be determined at the moment that it is discovered. As the law is written, you could wait 3 months to look into that. So I don't think that the law is reflective of the practice. So that's one of the problems that we have. The other problem that we have is define what is a CQI. Is it a near miss? So the wrong drug got in the bottle, but the pharmacist found it before it went out. Is that, well, obviously that's depending, that it could be, it's not really clear in the law of what that, is that, does that qualify? Because clearly the pharmacist did their job and stopped it, but somebody could say, well, there was a problem up above. But the reality is, for all this, we have a duty as a professional to ensure that mistakes are fixed and followed up, and we have a duty to do quality work, regardless of what the law says. So to make us do our duty and then follow this rigid thing that may not be germane to how we're gonna, that's why we're here.
Representative Tellez.
Thank you, and thank you for taking my question. In healthcare, hospitals and medical practice setting, right now, CMS is issuing a lot of mandates that are really incentivizing or, creating behavior change and practice change as far as these kinds of things, regulatory things. Is there anything similar in the pharmacy world that maybe an accreditor or a funder is requiring quality improvement?
Yeah, so CMS, Joint Commission, the accrediting bodies, all, and the reality is, in order to get paid now for pharmacy, it's becoming more and more likely you're going to have to be accredited by somebody, and that's the whole point of accreditation, is quality and quality assurance. And the benefit of accreditation is they can move their standards much more quickly than if you try to put something in law. I mean, we all know that we're always chasing that. As legislators, are always chasing something. The accrediting body that doesn't have to go through this process can move much quicker, respond much more nimbly, and do a better job at addressing really issues in safety.
Other questions? Representative Leon.
Thank you, Mr. Chairman, and thank you for presenting this. So my question is, in the part that's retained, it continues to say that this program is non-putative and seeks to identify weaknesses in processes and systems. My question would be if it actually be more beneficial to repeal that, because the entire chapter, because while the intent is not to be punitive, doesn't that tie your hands if there is some pharmacy that continues operating and is just throwing caution to the wind and not doing it appropriately? Would it make more sense to repeal the whole thing?
Well, as I said, that was the initial desire of the Board of Pharmacy, is to repeal the whole thing. We don't feel that, I felt like going forward, I just want to underscore our point of pharmacy board is safety. So I don't want to misrepresent or represent that we are not concerned about safety. However, if we repealed paragraph 1, I don't think the safety of New Hampshire would be compromised at all.
Other questions? I'm seeing none. Thank you.
Thank you.
Also signed up to speak is Kathy Bizarro Thunberg from the New Hampshire Hospital Association. And you've asked for 2 minutes.
Good morning, Mr. Chairman and members of the committee. For the record, my name is Kathy Bizarro Thunberg. I'm the Executive Vice President, New Hampshire Hospital Association, representing the state's acute care hospitals and all specialty hospitals in the state. I am here today to testify in support of House Bill 1042. Our hospitals take great pride in the work that they do every day in support of the patients that they serve. Part of that work is continuously reviewing their quality of care and services provided, and that they are delivered consistently, accurately, and professionally. Hospital pharmacies do utilize continuous quality improvement, or CQI, protocols that are integrated with their hospital's overall quality improvement programs. We support the removal of the specific requirements of hospitals' pharmacy-specific CQI program and the reporting of summarized reports to the Board of Pharmacy. These details of the program and the statute were redundant and unnecessary since hospital pharmacies already incorporate their work in hospital operations and overall CQI programs. I would suggest, however, that if the first part of the statute remains, that another part of the statute should also stay in place to ensure that these types of programs remain confidential. And in my handout, in my testimony, I did note for RSA 318-45A, paragraph 6, CQI programs shall be confidential, and continuous quality improvement records shall be considered peer-reviewed documents and not subject to discovery in civil or administrative actions. The reason for this is because CQI programs are important because they promote a culture of openness and trust in reporting errors, near misses, or other issues with the goal of finding areas of improvement without fear of reprisal. CQI programs often must include sensitive information related to patient care, and keeping this information confidential is essential to the privacy and security of the individual. Overall, CQI programs focus on improvement and not blame. So for that consideration, I do wish that the committee support 1042 with the consideration of this proposed amendment. Be happy to answer any questions.
Okay. Thank you. Representative Weber.
Just to be clear, I understand your concerns about keeping the confidentiality issues. Am I to understand from your testimony that you would be equally okay if we repealed the whole thing?
So I did speak to the sponsor about that. I think it does make sense that if they do repeal the entire statute, that we're okay with that. Because hospital pharmacies, as I mentioned, do integrate their CQI programs within hospital overall operations. They do also have confidentiality provisions there as well. But if we were going to keep something separate for pharmacy in the pharmacy statute, I think it would have been appropriate to keep it there as well. But I think we're okay with the overall repeal.
And just as a
Follow-up.
follow-up to that, and the hospitals have accreditation and programs and many compliance overseers that will
Absolutely.
require this. Is that correct?
Absolutely, yes.
Thank you.
Representative Leon.
Thank you, Mr. Chairman, and thank you for bringing this issue to our attention. Without this law at all, is there a challenge that any other regulatory bodies, the payers, the federal government may try and violate that, try and reach through that confidentiality? And would we need to proactively protect these programs, whether through this bill or something else?
I don't believe so. I think we already have that current confidentiality in place for other CQI programs. So as long as pharmacies fold in with other existing programs, I think we're okay. I will verify that, but I think we're fine.
Thank you.
Other questions? Okay, I'm saying none. Thank you.
Thank you.
No one else has signed up to testify on HB 1042. One person did sign the blue sheet in the back indicating they were in favor. And we'll let you know in a moment how many signed up online.
Online, there were 2 in support and 2 opposed.
With that, I am going to close the public hearing on HB 1042 and open the public hearing on HB 1609. And recognize the prime sponsor, a member of our committee here, Representative Jim Murphy from Hanover. Good morning, Representative Murphy.
Good morning, Mr. Chairman and fellow members of the committee. Thank you for allowing me to introduce this bipartisan act, which is relative to the Commission on the Primary Care Workforce in the State Office of Rural Health. I believe I gave everybody a copy of my written testimony, so I am not going to read the entire thing. I'll probably try to summarize. The first page entirely goes over the alphabet soup word acronym of all the various entities in play here. And I just wanted to try to briefly summarize some of the historical timetable behind each of these. Back in 2008, the State Office of Rural Health, SORH, was created. It sits under the section of Rural Health and Primary Care, RHPC, which is also part of DHHS. The intent of the State Office of Rural Health was really to seek long-term solutions to the challenge of rural healthcare, particularly in underserved areas, and with a focus on primary care specifically. Subsequently, back in 2010, House Bill 1692 then authorized the SORH, the State Office of Rural Health, to create the Professional Data Center, HPDC, and that was to collect data organizing and regarding the state's primary care workforce. It was with the intent of not only understanding the primary care force today, but also to understand and try to predict what would be needed in the future, and to basically try to serve as a bellwether of what primary care would look like in the state, particularly in rural and underserved areas. That statute also created the Commission on Primary Care Workforce, of which I'm a member, and it's their duty to basically take the information and try to understand primary care in the state of New Hampshire. So if you go to the bottom of the first page, it also speaks to the OPLC. I think we all know that is the Office of Professional Licensure and Certification, which was first brought onto the scene about 10 years ago. And they basically provide the administrative support for over 50 professional licensing boards, councils, and commissions. OPLC collects data regularly from the applicants for these surveys and for the licensure, and is directly reports to.
Representative Murphy, could I
Yes.
interrupt a moment?
You seem to be,
Microphone.
sorry, you seem to be referencing your testimony, and I don't have a copy of your testimony. Has that been handed out?
It was. I gave you
It
one.
was
I'll give
handed
you
out
one.
yesterday.
Oh, okay, sorry.
I'll give you one
My-
tomorrow. I'll give you one. I have another one for you. And if anybody else does not have one, I thought I gave them up to most people as well. So that's the first page. It's really the acronyms and all the historical background to all the different players regarding this. So why this bill that we need today? First, it's to, as we regularly do, we extend the commission. So we want to extend the role of the Commission for Primary Care Workforce to continue to do their work. It's also to help OPLC and the Office of Rural Health share information so that they can basically dig deep into the information and really understand through this information what the primary care force looks like. And why are we doing this? It's because, as we all know, primary care is taking a terrible spiral throughout the country and regionally. We have members in our committee that are in primary care. And I think all of us recognize that primary care is really, the number of primary care providers is dropping off substantially, such that you see regularly articles in the paper or in the news about people that can't access or get access to good health care because they don't have a primary care provider. What is your alternative if they don't have a primary care provider? They can either not get care, we know that's not good, or they can go to emergency room, which is very expensive care, and it's usually when it's an issue that's fairly far down the road. That doesn't really help with the continuity or the quality of health care, and actually increases morbidity, mortality, and costs throughout the system. Why do I care so much about this? Because access is such an important part of healthcare. Access to primary care, to specialists, to whomever, but access is important. Access can be compromised in a number of ways. It can be compromised by a pandemic. People just don't go to see anybody in healthcare. Healthcare can be, or access can be compromised by insurances. Well, that's another subject altogether. But primary care access, or the lack of primary care access, is really what we're talking about today. And trying to understand primary care access in the state is critical to understanding healthcare as it's delivered in the state. So probably nothing serves better than good clinical examples. Why is access important? If somebody is having chronic headaches, and they're severe headaches, and they don't seek care, they may just have a migraine, or they may just have a headache from stresses of the day, but they also may be in a hypertensive crisis. And what is that if they're not treated, if they don't go to see somebody, if they end up in an emergency room maybe too late, maybe only once they stroke or they have a stroke that they actually do present. So primary care access is very important. Most of people's interactions with the healthcare profession are oftentimes through their primary care provider. I don't know the exact percentage. I would anticipate that's a huge number or a large percentage of visits that patients have are to their primary care to get their medication straightened out, to get their referrals for preventative care. So without primary care, who's going to make the referral for their routine mammogram? Who's going to determine when their next colonoscopy is due? Who's going to do the pap smear for them? Who is going to send them to the dermatologist for a skin lesion? Who is going to do any number of the preventative services that we do, blood work for PSA? That usually all centers and comes through the primary care office. If they're not there, that is not getting done and patients are not being served very well. I had the example or an experience not quite a while ago now, probably about 15 or 20 years ago. A nice man, probably mid to late 50s, comes in with what he called a bunch on his thigh. I had no idea what a bunch was. And I came to realize the common vernacular in northern New England is a mass. I didn't know what that was. I also didn't know what a shock was. A shock is a stroke. So there's a lot of the terminology that I was not aware of. But in any event, nice man comes in with a bunch. And he's got a gown on, and I'm looking at his leg. And there is a bunch, a mass, probably the size of a cantaloupe or a small watermelon on his thigh. And my question was, how long has this been here? That would be our first question. And I was told it was well over a year. And I said, why didn't you see anybody? He says, well, I don't have primary care. Yeah, I'm in the rural area of the state, North Country somewhere. I don't have any access to primary care, and to go to the hospital would cost me too much money, and really the nearest hospital is 20, 30 miles away. And I said, so what brings you in today? And he says, I just couldn't put my pants on anymore. And the problem with that is, obviously, this was diagnosed well too late. Had we seen this person as a referral from his primary care provider when it first happened, he could have been saved. So in any event, these are just these are just a few examples of why primary care is so important. Primary care numbers are dwindling right now. We need to understand what our primary care workforce looks like. We have to try to anticipate what the workforce will look like in the future. The work of the Commission on Primary Care Workforce, working with the OPLC, gaining the information that's necessary to understand where these providers are, how old they are, when are they going to retire, what is their specialty, are they internal medicine, family practice, pediatrics, OBGYN. We need to understand this. If we don't have the information, we can't understand the practice of primary care in the state. And patients will, and many of us who have trouble finding primary care will not get the care we need in a timely manner. So there's a lot of other issues regarding, previous laws and stuff like that. And we have people here that will speak to exactly what is their needs. But I would urge us to at least extend the commission and allow information to be shared with OPLC and with the State Office of Rural Health so that we can better serve our patients. And I'll be happy to take any questions.
Thank you. Representative Weber.
So basically, after all that, what you're asking us to do is simply continue the work of two bodies that are already established for another 5-6 years?
Till 2029.
Right. And so that any of us who were already concerned, as I suspect we all are, about the state of the primary care workforce, this would be one way of helping to understand where we are and where we may need to be in the future.
I couldn't have said it any better.
Okay, thank you.
When you think of it, if we don't understand our primary care workforce, how many are going to age out in the next 5 years? How many are going to be coming into the state? How do we not only understand where we are today, where we're in the future, and how do we encourage recruitment and retainment of primary care? That's the scope of this body, of this commission.
Thank you.
Representative Seth King.
Thank you. Thank you, Mr. Chair. Thank you for taking questions. Could you maybe calm my skepticism a little bit about the commission. How long has it been around, and what has it really achieved? And I ask that because I think we kind of already know, all of us, why there's a shortage of primary care physicians. I mean, who wants to go hundreds of thousands of dollars? There's less incentive to become a doctor. Hundreds of thousands of dollars in student loan debt. You work terrible hours. You're constantly battling with bureaucracy and Medicaid and the insurance companies. I mean, we know what the problems are, but we as legislators clearly aren't fixing it. And we create these commissions, I think, to placate our guilt. And I'm not sure if they're coming up with any solutions we're willing to implement. So I'm not sure what the point is of keeping something like that going alive. And then also, can you explain a little bit? I'm still not 100% sure what the new paragraph is, where it inserts, where it talks about what OPLC is going to do. Are they going to create new rules and regulations, or are they just giving information that already exists? I'm just a little confused on that. So if you could answer those two
So
questions. that'd be great. Thanks.
multiple questions. Thank you for the question. And I would totally agree with you, Representative King, that it's not that your reference in the question is healthcare broken. That's why we don't have primary care providers. Though primary care is probably one of the most gratifying specialties in all of medicine. They're the ones that actually make the contact with the patient. They develop the relationships. I was a specialist. I had episodic care. Yes, I had patients that came back for another broken bone, but I didn't see them on a weekly, monthly, or yearly basis like a primary care provider does. So it's a time-honored profession. In fact, when those of us that went to medical school that are on the committee would tell you that back in the day, probably the most revered position in the hospital was the chief medicine or the chief resident of internal medicine. And that's because they were probably considered the smartest. They were considered the brightest. And so I don't know if I totally fully understand all of the reasons why, primary care is dwindling. I have my ideas, and I would ask others on the committee, they can share it as well. Is it reimbursement? When we went to a reimbursement model in the 90s where you were paid for procedures versus, quality time spent with the patient, that's when we saw a number of the people going to the primary care diminish. And it's difficult to practice primary care in rural health settings when you don't have, a hospital setting nearby that you can rely on comfortably and reliably on a day-to-day basis. There's a lot of issues in primary care, and I would not speak to them only because I think there's others in our committee that can do that. As far as what has been done with the State Office of Rural Health, we have representatives from that office here today. They can actually, better than I, tell you exactly what they have done since it started. It was, when you asked me before, it said, when was it first created? That was in 2008. And so when that was created in RSA 126-A:5, that's when it was started in 2008. And that has been their goal since then for the past 15 years. And it's also in statute that has to be re-upped every 4 to 5 years, whatever it is, so they can continue the work. But I would bet you, and I'll let them speak to that because they can do that better than I, that their work has been substantial. And if nothing else, to understand where we have deficiencies and gaps in our care, that's critical when you're trying to work with the federal government in trying to recruit people. Where do you recruit them? What specials do we need? And that sort of thing. So otherwise, we're working blindly. When you don't understand the demographics of a certain profession like primary care, we don't know where to fill the holes. We don't know how to, do we need more primary care and family practice up north? Do we need internal medicine? Do we need pediatrics? What is it that we need and what are we lacking? But I will let them speak to that one.
Representative Cushman, and then Representative Shapiro.
Thank you, Mr. Chairman, and thank you for bringing this bill. My question is, with your experience on the commission, specifically talking about gaps in care, I've had very good experiences with direct primary care, and I've run into a lot of people who may not have insurance, or they find their insurance lacking, they don't like the network, or whatever reasons, and they need some semi-urgent care, but not enough to rise to the level of going urgent care, and they can some of these gaps can be filled in by direct primary care workforce. And I was just wondering what the general attitude is of the commission toward that particular flavor of primary care, and if there's any representation for the direct primary care providers on the commission.
Great. It's a great question, because it also speaks to the fact that there are multiple points of entry into the healthcare system that, if we utilize them correctly, it is effective, and it's good quality care, and it's also, you know, cost effective. So going to the emergency room for what you were talking about is really not cost effective. I have to admit that I've only been on this commission for less than 6 months. I was asked to be on it as the House of Representatives representative on the committee, but I think the folks behind me that are on the commission can speak to that better than I, specifically regarding that question. But thank you.
Great, thank you.
Representative Shapiro.
Thank you, Mr. Chairman. I'm not sure you can answer this now that I know you've only been on the commission for 6 months, but to piggyback on Representative King's question, in Keene at Cheshire Medical Center, we now have a new family medicine residency program, which will bring residents to the Keene area to be trained with the hope that they'll stick around after they're trained. Is this, and I know that's a very expensive and tremendous amount of work to start something like this. So I'm wondering if this is the kind of project that potentially or in fact comes out of the commission's work.
One of the charges of the commission and the State Office for Rural Health is specifically for recruitment and retainment of professionals in rural and in underserved areas. And that's a perfect example as why that residency, I know I'm familiar with that family practice residency when it was started. And that was exactly the reason we did that. And the reason that's important, and that's the focus also, because that is also understood when you understand, when you get more information about the demographics in the state. Where are people coming from? Where are primary care doctors coming from? Well, that's a great resource. So what is really notable is in residency programs, in you know, whether it was in orthopedics or in primary care, if you train in an area, the likelihood of you staying in that area is substantially greater. So when you start you know, we had residents that came from Texas to our orthopedic program, and they said, no way, I'll be here for 4 years, get educated, and get out of this god-awful, you know, snow belt up here. And half of them, if not most of them, all requested to stay on staff after they were done. And so if you get them in the door, when you get them in the door and they see the place, they understand the place, that's exactly what we would be looking at. That's exactly the type of feeder programs that we need. When I was the chief medical officer at New London Hospital, we would have some of the osteopathic physicians come over from Maine in their program. And I would say 1 in 2 would actually stay and request to stay on staff after they graduated. So this is exactly what we're trying to do. But we need to understand where these opportunities are. What are the potential inroads to primary care that we can cultivate and then try to recruit and then maintain them in the practice of primary care in the state. Thank you for that.
Representative Merchant.
Thank you, Mr. Chairman. And also thank you, Representative Murphy, for taking my question. Given the time you're putting into the commission, can you tell me how you're compensated? Is this volunteer work or is this something that you're being paid for?
This is New Hampshire, remember that.
That's the point I'm trying to make.
So I will say that since I retired from my practice, having been on hospital boards, fiscal policy boards, in the House of Representatives, and on this commission, I have not generated a W-2 form at all. I get paid, well, we all get paid what we get paid for the House. Beyond that, I do not get any extra pay for this commission at all. But I'm happy to serve on it because, frankly, the access to primary care is one of my passions. Despite being a specialist, it is one of my passions.
Thank you.
Representative Nagel.
Thank you, Mr. Chairman. This is really more of a comment, and since we've gone down into levity, I would ask that we put into permanent record the comment that a surgeon stated very publicly that the smartest person in the hospital is the chief resident in internal medicine.
Would you not agree with me?
I think hell just froze over, and I totally.
Other questions? Representative Palmer.
So obviously this is near and dear to my heart because I'm working a lot more this year because there aren't enough people coming in. But the pipeline is important, and I'm asking this now, and other people hopefully will comment on this. Is we have one medical school in New Hampshire. There are a couple of residency programs that have started. The one in Keene. There's one in Portsmouth, which is great. But we have one medical school, which is a private medical school, and it's expensive. And a lot of the people that go to that medical school are planning to go into specialties and not necessarily focus on primary care. Is the commission looking at all at trying to figure out how to get, another medical school or medical students here? Because
Well, thank you for that question, and I'm totally sympathetic and empathetic with that question and that concern. The short answer is no. From my understanding, again, I'm a 6-month veteran on the service here without pay. But having said that, I think that the primary focus is to understand the gaps in healthcare and primary care in the state, where they exist, what specialties exist in primary care, being multiple specialties, as you know, and then how to recruit and retain. If they are doing work on trying to build another medical school here in the state, I'm not aware of it. If we're working to try to incentivize medical students to go into primary care in some way or another, I'm not aware of it, though that would certainly be an offshoot, and I can let them speak to that as far as the recruitment and retaining. But as those have been here for a while in medicine, understand the mid-90s when we instituted what they call an RVU, a relative value unit for reimbursement, that dramatically changed the landscape of healthcare and the professions that people went into, so that proceduralists were getting paid more, but the people that spend more quality time, like Dr. Palmer, with patients day to day, were not being reimbursed adequately enough. I think that's beyond the scope of the commission, though we can actually try to recognize it as a concern and try to then promote through the legislature potentially, programs that would enhance recruitment and retainment of primary care providers. But thank you.
Other questions? Seeing none? Okay, thank you. Also signed up to speak are Danielle Hernandez and John Williams, attorneys with the Department of Health and Human Services. And you've asked for less than 3 minutes.
Good morning, Chairman McDonald and members of the Health, Human Services, Elderly Affairs Committee. For the record, I am John Williams. I am the Director of Legislative Affairs for the New Hampshire Department of Health and Services, and thank you for this opportunity to come before you today on HB 1609. And with me is
Danielle Hernandez. I'm the administrator of the Health Professions Data Center, or HVDC, which exists under the State Office of Rural Health, or the SOAR. We love our acronyms at HHS.
And we are here in support of the entirety of the bill, but specifically want to thank the commission because part of their charge also includes the collaboration between our agency and Ms. Hernandez and her crew at the State Office of Rural Health. And keeping to the 3-minute time limit, I just wanted to let you know the good works we did on Section 3 of the bill, starting on lines 13 through the remainder down to 18 prior to the effective date. So we have a very good collaborative relationship with the Office of Professional Licensure and Certification. And we have under our statute, under RSA 126-A:5, Roman 18, lowercase -a, the ability to receive and to collect certain information that is helpful to us to provide information to the commission, to the legislature, as it relates to the licensed individuals, whether they're dentists, whether they're doctors, and a whole slew that you'll see in our enabling legislation for targeting the information for those folks. I just want to remind, it is a voluntary process. There is an opt-out provision. We have the wonderful prime sponsor. Again, I can't believe it today, is deja vu from Representative Lori Harding, who's in the audience, who actually helped and worked collaboratively with Senator Carson at the time around very thoughtful provisions in legislation. So we're entering into what they call a memorandum of agreement with our other agency, working collaboratively with the Office of Professional Licensure and Certification. And they very thoughtfully identified that we in the department already have this authority and have been exercising it, and we've been protecting data, and we've been giving good information. But they identified, and you'll see on line 14 of the bill, that it amends RSA 310.5. That essentially is their enabling legislation for their authority for doing certain things. And so this would be an additional item to provide them with the same reciprocal authority, and it cross-references back specifically to the RSA that I quoted, and because of 3 minutes, I won't quote it again, but it is in the bill itself. And that is exactly what we're doing. So this language was worked on in collaboration of both agencies, and we're here today to represent that it's a wonderful thing, putting belts and suspenders, and to include in their provision of law that reciprocal authority. So with that, I do know we have a brief amount of time, so I do want to turn it over to Ms. Hernandez, because she really has a volume of information in terms of the merit and the work that's been done, not only by the commission, but specifically by the State Office of Rural Health, which she serves in that capacity, does a wonderful job, and also to respond to various questions by the committee members that have been raised. So with that, I'll turn it over to Ms. Hernandez, and then to questions from the committee. Representative McDonald, thank you so much.
Thank you. So HPDC, the Health Professions Data Center, was developed under the SOAR to receive available data, as John had said, and collect data through provider surveying during license renewal to assess the current and anticipated primary care landscape in New Hampshire. This initiative was codified in 2019 with a requirement for HPDC to report to HHS oversight and to inform the work of the Legislative Commission on the interdisciplinary primary care workforce. So this data really has significant impact and value. It helps to support and strengthen federal shortage designation performed by our office, which brings primary care providers and grant funding to rural and underserved areas of the state. It supports recruitment and retention initiatives, including, among others, the State Loan Repayment Program and New Hampshire Recruitment Center. It supports the development and expansion of existing educational and employment training programs, most recently Coas County's Family Medicine Residency in Berlin, and as was mentioned earlier, Cheshire's Family Medicine Residency in Keene. And of course, it supports it strengthens emergency preparedness. So OPLC collects and maintains a number of licensing fields fundamental to provider surveying, shortage designation, and workforce assessment. Without access to these fields, HPDC effectively loses its ability to fulfill our statutory and federal grant requirements. We have been receiving this data through a data sharing agreement until August 2023, just recently, when it was determined by OPLC that they would need the statutory authority to share data. And this bill does exactly that, right? It grants statutory authority to OPLC to share workforce data-related fields with the SOAR, which already has the statutory authority to receive it, effectively just closing a legislative discrepancy. All but one licensing field is public data. The one non-public data field, provider email, is essential and used for provider compliance follow-up to increase response rates. So as is the case with all licensure requirements, the survey requirement is verified through provider attestation on the license renewal form. Unfortunately, we still see, even 3 years after the survey was implemented as a condition of renewal, non-compliance rates between 15 and 25%. When our program, HPDC, sends out that reminder email to providers, it's reduced to about 1 to 4%. So without our hand in the compliance office, what would happen is the final non-compliance list sent to OPLC's enforcement division would increase significantly, and we risk losing reliable representative data that can only come with higher responses, and is also, critical and necessary for shortage designation work and provider to population analysis to determine need.
If you could start wrapping up, please.
Yep. And that's really it, just to continue this valuable work around workforce and to inform policy, where DHHS is in support of HB 1609.
Thank you, Representative Cushman.
Thank you, Mr. Chairman, and thank you for speaking to how you see this bill's value. I am wondering, you mentioned a voluntary process for opt-out of something, or actually it was Mr. Williams, I believe. Can you, I didn't catch what exactly you were referencing.
So when the survey was implemented as a condition of renewal, we wanted to ensure that, quality practicing clinicians weren't at risk of losing their license based on a survey. And so it was important to us to also implement the completion of either the survey or the opt-out form. They exist on the same page on DHHS, and providers can certainly choose the opt-out form to say, this is my name, like minimum data points for shortage designation use, name, specialty, if they practice in New Hampshire, and that fulfills a requirement.
Follow up.
Okay, thank you. That is very helpful. So now I'm just trying to weigh that against what you said about, you're chasing after compliance. So you need their email address because you need those answers. And when you were saying that, it was interesting to me because I didn't know that there was this opt-out, because as a nurse, I have to fill out the survey during my renewal process on the OPLC website every 2 years before I can even finish it. So I'm just trying to kind of square that, how, where we have the opt-out, but now we're kind of want to make it that it's involuntary, or that there's more pressure, more ability for there to be more pressure to fill out the survey, for lack of a better phrasing.
Sorry, for clarity, the compliance follow-up is for providers to complete either the survey or the opt-out form, and that's made clear in the email communications that are sent out.
Other questions? Representative Leon.
Thank you, Mr. Chairman. It sounds like the Board of Nursing has a more streamlined process through the OPLC. Do you know if all the other relevant licensing boards are moving to that same process where we won't have that same compliance because you can't complete it without the opt-in or the survey going forward? The way the survey is implemented for all participating provider types is consistent. So every clinician that participates under their respective boards has the opportunity to complete either the survey or the opt-out form. And it was a recent move in the last 5 years that all health professions boards have transitioned from paper renewals to online renewals, just to streamline that process. Thank you.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. So without this commission, are there other ways to get federal shortage designation and receive the respective federal grants?
I'm sorry. Can you repeat that?
If not for this commission, are there other ways to receive federal shortage designation?
What the commission has done for this portion of the work is it was really through the commission, through recommendations, that the SOARS Health Professions Data Center was established through legislation. So that's really, and through that legislation, we also have the reporting requirement to inform their work, which we do throughout the year.
Other questions? Seeing none? Okay, thank you.
Thank you.
Thank you.
Also signed up to speak is Christine Stoddard from the Bi-State Primary Care Association. And you've asked for 2 minutes.
Good morning. Thank you. As the chairman noted, my name is Christine Stoddard, and I am the Director of Public Policy at Bi-State Primary Care Association. And I'll try and do my best to answer some of the questions that were asked. that relate to our community health centers. So Bi-State is an advocacy organization that works to expand primary care access to all New Hampshire residents, including in the districts that you serve. We also represent community health centers, including federally qualified health centers, which can only be established in the country using the data that is collected by departments and divisions like the SOAR. We could not access federal programming without the data that their organization collects. In 2022, our community health centers served or had over 408,000 visits. So these are primary care visits that include substance use disorder treatment. We use a very broad definition of primary care. Substance use disorder treatment, oral health services, what you would typically think of when you think of primary and preventive care, including reproductive health care services. We rely on the data that is collected by SOAR and the conversations that happen at the commission to advocate at the federal level for funding that directly benefits your constituents and the districts that you serve. And Representative Seth King, to answer one of your questions that you asked, there are community health centers that serve your district. There are 4 clinicians benefiting from the state loan repayment program in your district alone. And they wouldn't be able to do that if we didn't have the information collected by SOAR and the work of the commission. So it is very important. We do support House Bill 1609 because of its work, and I can't overstate the importance of the commission. It did help, as Danielle noted, us to establish the Teaching Health Center residency program at Coos County Family Health Services, and that was done in partnership with UNE and Geisel School of Medicine. They are also partnering with the hospitals in their area to ensure that the 4 residents that they plan on bringing in 2025 can serve the North Country in a culturally appropriate way. And we do our best to retain those residents once they complete their residency program. Just the FQHCs alone have 131 vacancies, and that's 10 organizations. So being able to access the data that SOAR collects, and as I noted, the work of the commission is very important to our ability to decrease those vacancies and also recruit and retain additional clinicians throughout the state. I think most other speakers have answered a number of your questions that you've had, so I'm happy to answer any more if you have them, but I know you're already backed up, so.
Thank you. Representative Neto Upham.
I didn't listen quick enough. Thank you for taking my question.
that's okay.
You have 131 vacancies in New Hampshire for
Yes.
doctors?
No, that actually runs the gamut. So that includes front desk staff, MAs, RNs, APRNs, MDs and DOs. It's across the health center workforce.
Is it possible to see a breakdown of those numbers?
Yes,
in
I'd
an
be happy
email?
to get that. Sure,
Yeah.
I'd be happy to get that to you.
Okay, thank you very much.
You're welcome.
Other questions? Okay. Anyone else? Seeing no one else, thank you.
Thank you.
Also signed up to speak is Mary Bitgood Wilson. And you've asked for 2 minutes.
I think I can do it in less than that. You have my written testimony. And so instead of highlighting points from that, I just wanted to answer some questions. I'm a family nurse practitioner and a certified nurse midwife. I've practiced in New Hampshire for about 40 years in the Lakes region. And I'm the chair of the Legislative Commission. So the commission was established in 2010 was someone's question. In response to your question about direct primary care, we have had a short presentation regarding it, and one of the direct primary care nurse practitioners in the state is now attending the meetings as a guest and hoping to make that more broadly integrated into our interdisciplinary committee. We worked very closely with UNE over the last 5 to 6 years. 2 of their faculty members are now guests almost every month at our meetings, and we've established clinical rotations for those medical students in New Hampshire. Again, underscoring, if you train them here, they'll stay here. We worked very hard to the development of the 3 residency programs. The North Country, which is unique in that it is a rural residency program, and then the first class that's graduating from Portsmouth this year. They graduated in July, and then the first class that will be starting in Cheshire this June. And we worked very hard with a new project at UNH, which is for advanced practice registered nurses. And the statistics there are about 85% of them stay in state after graduating from the program. And we worked with helping to validate and extend the AHEC federal program. So I think those are most of the questions that I heard.
Okay, thank you. Any questions? Representative Cushman.
Thank you, Mr. Chairman, and thank you. Just a quick question. Thank you for answering that question about the direct primary care. It sounds like they are kind of able to come and have the conversation, but do you think it would be appropriate to put in an amendment, since they are an expanding branch of the primary care workforce, to add a position for a representative of that particular brand of provider?
Yes, we try to really be very inclusive and very interdisciplinary. And I did a short presentation on this last fall, and many people think it is the wave of the future. That people, especially with the huge deductibles that people have, that it is for healthy young families, it is a way for them to access primary care in a affordable but very comprehensive way.
Other questions? Representative Tellez.
I have a question, actually, it's follow-up to your question. So would you say the membership is employers or sort of representatives of disciplines? And then to follow on, if you were to have, like, what would you call the category of entities that, what is it,
Well, we-
Direct MD or whatever she called it? The
Direct primary care.
Direct primary care would be, yeah.
I don't know if they have a official group that meets or not. I guess I would need to explore that. But certainly having them come as a guest has been valuable. The rest of the commission, it kind of runs the gamut from the New Hampshire Medical Society, the Nurse Practitioner Society, to UNH, Geisel School of Medicine, Bi-State. There's a listing of all the different organizations in the written testimony.
Other questions? Seeing no other questions, thank you.
You're welcome.
No one else has signed up to testify on HB 1609. On the blue sheet in the back, 3 people did sign up in favor of HB 1609, and online.
Online, there were 33 signed in support and 1 opposed.
With that, I am going to close the public hearing on HB 1609. Those are the only hearings we have scheduled for today. We're going to take a brief break of maybe 10 minutes, and then we'll reconvene and get into executive session.
And Mr. Chair, you're planning to end by 12, is that correct?
Yeah.
Because we have
lunch and
an ongoing obligation at 12, so all of the Dems.
I was going to say,
We wanted to put today.
1042, the quality assurance.
Yeah.
Pharmacy ahead of them. We feel it.
Absolutely.
I like how they color coded.
And the other thing I was going to ask was
Want me to grab the other one, Bill?
about support for repealing the autism registry, because it seems to me that once you deal with all the things that can be withdrawn, the data is no longer good data. And the only person who supported keeping it was Chris Munns, who established it.
There are some vaccine people, let's say, one vaccine activist who would like it to be kept.
The autism.
Yes.
Okay.
Handed that amendment out yet.
Okay, people could start taking their seats, please. Is everyone here? I think so. I don't see any. Representative McKay is coming. But you're coming, that's the important thing. Okay, I'd like to convene the executive session. We have 35 minutes before the caucuses. Both parties' caucuses begin across the street. So in the interests of time, we need to get started. Change the order around a little bit. We have 4 bills to consider in executive session today. We'll get as many done as possible. Starting off with HB 1604 FN. Representative Nagel, I believe you have an amendment.
Thank you, Mr. Chairman. I would like to move ought to pass amendment 2024-0728H.
That's coming around now, I
Yep.
trust.
HB 1604.
Okay, is there a second to that motion?
Second.
Representative Merchant seconds. Would you like to speak to your motion, Representative Nagel?
In response to our very wonderful discussion yesterday, basically all this does is it changes what was line 8 in the original bill. It's now line 3 in the amendment, to basically limiting this provision to any health carrier that operates in the state of New Hampshire, not any federal insurers. So in other words, it doesn't apply to Medicare, Medicaid, which we knew going into this. Now we're putting it in writing. There were concerns from a number of stakeholders that might be a problem. We believe that this line fixes that.
Okay.
Other than that, it's the same bill.
Anyone else wish to speak to this amendment? Representative Kofalt, then Representative Weber.
Yes, thank you, Mr. Chairman. So I just want to make sure that I understand clearly, based on what I see in line 1, this would effectively delete section 3
Yes.
from the original bill. Thank you.
Yes, and that was part of, oops. Top down. Yeah, that was our discussion yesterday as well. I mean, I'm not, in my world, it's not ideal, but that's a fight for another day.
Okay, Representative Weber.
And following on to Representative Kofalt's question, the amendment we had yesterday would have deleted 3 in its entirety, is that right? Okay, so we were referring to section 3 yesterday, not 1 or 2. 1 or 2 stand, this is the replacement. Thank you.
On the original bill, the first section 1, which just defines electronic medical record, that still exists. Section 2 is changed as is here. Section 3 is eliminated, and the last two effective dates still present. You should all make sure I'm correct on that, because when I got this, it confused me to death.
Other questions?
And if I'm
Go ahead, sure.
following on, yeah, and this does, because it says amend 2 and 3 is inserted by section 1 of the bill by replacing it with the following. So 3 is gone, 2 is amended, 1 is still the same, and we're all good. Thank you.
Thanks.
Other questions? Other discussion? Seeing none? So the motion is ought to pass on amendment 2024-0728H. I'll ask that the clerk call the roll.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Polozov,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
Representative McDonald,
Yes.
20-0.
Okay, thank you. Representative Nagel, do you wish to make another motion?
I'd like to make a motion auto pass House Bill 1604 as amended by Amendment 2024-0728H.
Second.
The motion's been seconded by Representative Merchant. Is there any further discussion on this? Representative King, Seth King.
Thank you, Mr. Chair. I'm not going to spend too much time on this. I'm opposing the bill as amended. I agree with the general sentiment of not liking the electronic medical records. I don't, you can see here, I don't have a computer. I like to keep my paper records, and I definitely think that there have been a lot of problems with electronic medical records. That's a given. However, generally speaking, as I've mentioned times in the past, if there's some sort of problem in the code that's incentivizing health carriers to require it because maybe they have to meet deadlines or something, then we should look to remove that code. I don't really like adding new code. Generally speaking, I do believe that most problems we experience in society are government caused, and we should be looking to remove that cause, not adding new lines of code that's going to take away freedom even more. So a bill like this sort of presumes that there's never any conceivable reason why a health provider would, a health carrier would really need EMR, and I don't believe that. I think that in a free market system, competition would dictate what is really demanded. And there might be some healthcare carriers who, they totally work towards helping people stick to, paper records. And then there might be others that are really geared towards people that are perfectly happy with electronic medical records. And, if we had a bill like this in there, then they wouldn't be able to just serve that clientele. So I don't like the one-size-fits-all approach. Overall, it's not the end of the world, but it's just another one of these little bits of code that just makes it a little bit more difficult to comply, and it makes the whole process just a little bit more sclerotic, and I just prefer competition and letting the market decide which is best. I'm old school. I like my paper too, and I definitely see there's been a lot of problems, but I'm not ready to ban it completely. So that's why I oppose it. Thank you.
Representative Land, did you have your hand up?
Sure. Thank you, Mr. Chairman. To me, I just see this as something that's empowering doctors who don't want to have an electronic medical record to do so. That's why I'm supporting it. But I understand sometimes we look at the same bill and see it from different perspectives. And I absolutely understand that and respect that opinion. But I just wanted to say I think that this provides the doctors more choice. And I think that I think we probably all know where we stand on this one. But I thank you for sharing that.
Other discussion? Seeing none, I'll ask the clerk to call the roll. The motion is ought to pass as amended on HB 1604 FN.
Representative Land,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
No.
Representative Mazur,
Yes.
Representative Nagel, Representative Polozov,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
19-1.
You know, that can't be on consent because it's got a fiscal note, Representative Weber, is that correct?
I believe it has a fiscal note, but it has no appropriation in it. So because it has no appropriation, it need not go. It's not going to finance. So
Okay.
I think it's okay.
There's no objection, then we'll put that on the consent calendar.
I'm sure that the upstairs review will let us know if we've done that wrong.
Sure. And Representative Nagel, if you can get that report to me sometime this afternoon. Thank you, everyone, by the way, for getting the reports to me yesterday, so timely, and I did have forwarded them on to the committee services folks, and I really appreciate that. No minority report, I assume, Representative King?
Do I have to write one?
No, you don't.
I don't care
No,
to. No.
Okay. All right, then we're jumping around a little bit more. We're going to go to HB 1660 FN next. Do I have a motion?
Mr. Chair, I move ought to pass.
Motion's been made ought to pass on 1660 FN. Is there a second? So Representative Cushman seconds. Would you like to speak to your motion, Representative Kofal?
Yes, I'll be quick. As I said, when I introduced this bill, gender reassignment surgery for minors is something that many taxpayers think is a bad idea. It is medically not necessary, and we ought not to be covering it with taxpayer dollars.
Okay. Representative Weber. You just shut your mic off, by the way.
Sorry, thank you. And I would just say that I take the opposite position. I believe that, first of all, these surgeries are necessary and life-saving. I also believe that they're very rare, but this bill is more far-reaching than the bill we already passed, which was a ban. So it has the potential, in the case of the surgeries still covered by it, of creating a two-tiered standard of care and treatment. And I think that we have recognized in other cases that that's inappropriate. So for those reasons, I will be voting against the ought to pass and hoping for a different motion.
Okay. Other discussion? Representative Shapiro.
Thank you, Mr. Chairman. I'm not comfortable with minors having these kind of surgeries, whether it's bottom surgery or top surgery. And if it was someone who was in my circle, in my life, in my family, I would try to encourage them to do everything I could to wait until they were older to make a decision like that. Nevertheless, some of us might have noticed that there are about 20 bills limiting what transgender people can do or can't do. And we're not talking about other kinds of surgeries that are that minors have. And so I just think that this is discriminatory. And so I will vote against it because I don't want to discriminate against transgender people.
Okay, thank you. Representative Leon and then Representative Kofal.
Thank you, Mr. Chairman. I am not aware of Medicaid covering breast surgeries for minors unless there's a malignancy or that they're so heavy that there's back problems. If there is in fact a disparity between this, where transgender children wouldn't be able to have a top surgery that would be paid for as an augmentation or removal for somebody who's not transgender, I hope that you would all co-sponsor a bill with me next year in order to remove that Medicaid funding for anything other than a malignancy, something that's back pain. Let's figure out where those ones where any child can't wait until they're 18 for payment, and make sure that there is actually a true equity on this. But as far as I don't know that we cover that for anybody other than potentially transgender children.
Representative Kofal.
Thank you, Mr. Chair. So with respect to the concern expressed about a two-tier system, I will read from the healthcare.gov website. Many health plans are using exclusions such as services related to sex change. So there is not a single standard across the board for private insurance either. And I would assert that this does not create a two-tiered system in which Medicaid recipients don't have access to something that everybody else does have access to.
Okay, thank you. Other discussion? Representative Shapiro, then Representative Cannon.
Thank you, Mr. Chair. I just want to respond to Representative Leon. And because I researched this with Department of Medicaid, you are accurate that breast augmentation and breast reduction and limb lengthening and nose jobs are not covered if they're purely cosmetic. So I just want to say that that is accurate. I still think that the reason that we're constantly talking about what transgender people can or can't do, or what can be reimbursed and what can't be reimbursed, in my mind, is because we are discriminating against one particular group of people, and I don't want to be doing that.
Just a quick response since he was directing that towards me.
All right, very quick.
Thank you. I take issue with you saying that it's discriminatory. I think that treating children equally, that there's certain medical procedures that simply aren't available till you reach a certain age, should be the same for all children. And I think that it sets a false expectation of these surgeries being available. I view this out of compassion because it sucks to be a teenager for everybody. Let's focus on the fact that being a teenager is really, really hard and support people while not necessarily making it seem like early surgery is the solution to problems, because it's only one factor. We have to look at the whole child, not just the part that involves a scalpel.
Representative Cannon and then Representative Murphy.
If I understand, our responsibility as legislature is that we're here to protect the public and our constituents from problems. Our charge is to put controls in place where none exist. I contend in this situation, there are, in the medical field, there are controls, and that part of that is from the World Professional Association for Transgender Health. They don't recommend surgery for anyone under the age of 18, and they would rather that people get to the age of consent of adults over the age of 18. That said, I did some investigation on my own, and the National Institute for Health did a study. It dates back from 2013 to 2020. They identified 209 surgeries that were done. Out of that, breast surgeries, no genital surgeries. Out of that, they identified one complication, and 2 were postoperative regret, and neither of those people underwent reversal surgery. So in those cases, there was no problem that we would have to deal with that this legislation would catch. So I believe that this legislation only puts government in the way of the general public, and I don't believe it's needed.
Thank you. Representative Murphy.
Thank you. I'll be brief, and I suspect we all know where this is going to fall out in the vote. But I just want to make two very small points, basically. This is amazing to me that this is a procedure that gets probably more preoperative evaluation than any elective procedure I know about. So number one, I think it's done with thoughtful care for the patient and those in need for it. And number two, I was asking when this was presented by Representative Kofalt a week or two ago, does this include all surgeries? And he said yes. I talked to the folks at DH, and they categorically told me that they do not do these surgeries at DH. So I think it's important to understand that there's sometimes misinformation about what is done and what is not done. And they categorically, as a tertiary care, quaternary care referral center, do not do these procedures. Thank you.
Thank you. Other discussion, Representative Mazur.
Yes, thank you, Mr. Chair. I also, respectfully take offense to these bills being called discriminatory because the words, it was said that we're not talking about, that we're talking about trans people, but this bill is specific to children, and we are talking about irreversible procedures on children. So this isn't a discriminatory bill on trans people. This is a bill protecting children from things that can't be undone. So that's my statement on that.
Other discussion? Seeing none? Okay, the motion is ought to pass on HB 1660 FN. I'll ask clerk to call the roll.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Polozov,
Yes.
Representative Weber,
No.
Representative McKay,
No.
Representative Freitas,
No.
Representative Cannon,
No.
Representative Nutter Upham, Representative Shapiro,
No.
Representative Merchant,
No.
Representative Murphy,
No.
Representative Palmer,
No.
Representative Tejas,
No.
and Representative McDonald.
Yes,
10 to 10.
as was predicted. Do I have another motion? Representative Weber.
I was so hoping that somebody else would put their hand up, but I move ITL.
Representative Weber moves ITL. Is there a second? Representative Cannon. Is there any other discussion on this? Suspect we've kind of talked it out. So when the clerk is ready, Representative Tejas.
Yeah, I just want to follow on with what Representative Murphy said, that in fact, we have no evidence that this is happening in children, and the only place that does it in New Hampshire says they do not do it. It's on their website, and Representative Murphy followed that up with his own inquiry. And then I would say, I think it's discriminatory to not provide equal coverage to people who may happen to be on Medicaid for whatever reason. That's many people can end up on Medicaid for very different reasons in their life, and we should not be creating barriers for people who may be experiencing harder times at a certain point in their life. So that would be my add-on.
Okay, thank you. Other discussion on the motion? No, Representative Cushman.
Thank you, Mr. Chairman. To that discussion about Dartmouth-Hitchcock, respectfully, we did hear from them here in the committee, and they did not say that it never happens. They said it's rare, and I'd be interested to know if they would, state on the record in a legislative hearing that no, it's never happened. And additionally, I requested their policies and procedures and the body of medical literature that they rely on for performing such procedures. And they sent me back 2 surveys, behavioral science surveys, that talked about suicide ideation before and after hormones So I'm going to respectfully say that I don't have much confidence that this expert organization is providing us a full picture of what's going on with these surgeries, and they have not demonstrated that there's clear scientific body of evidence that they're relying for them. So, and the main point that I feel for this bill is that it's inappropriate for taxpayers to be paying for elective surgeries like this. So thank you.
Any other discussion? Seeing none, I'll ask the clerk to call the roll. The motion is ITL on HB 1660 FN.
Representative Leon,
No.
Representative Cushman,
No.
Representative Bill King, no. Representative Kofalt,
No.
Representative McLean,
No.
Representative Seth King,
No.
Representative Mazur,
No.
Representative Nagel,
No.
Representative Pelosi,
No.
Representative Weber,
Yes.
Representative McKay, Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
No.
10-10.
Okay, so that'll go in the calendar without a recommendation. Representative Kofalt and Representative Weber, you'll get those reports to me this afternoon. Thank you. It is now 10 minutes of noon. I know there's some interest in doing a little more work on the other two bills from yesterday. So we'll continue HB 1683 and HB 1568 to next week. It'll be quite a session next Wednesday for executive sessions, but we don't have any hearings that day, I don't believe.
We have two.
Oh, we do, okay. So it'll be a full day, but we'll make the most of it. So with that, I'm going to adjourn this meeting, and I know we both have, both parties have caucuses in 10 minutes, so we stand adjourned.